Moving on to our next session. Proceeding further, let's deep dive into understanding the controversy regarding antidepressants and placebos. Ooh, another great conversation. To lead the efforts of this discussion, I would like to welcome on stage our moderator. Please help me in joining up Alison Farley, founder of Doctors on Cannabis. I'd like to welcome up to the stage Bharat Agrawal. Woohoo! Thank you for that. Hello. Leigh Richardson. Hi, Leigh. Hello again. And Leah Henry. Nope, Leah's not here. Okay. And Samantha Elliott. There she is. Hello.
Hi, everybody. I'm Alison Farley, founder of Doctors on Cannabis. It's an educational platform for the cannabis curious that seeks to dispel stigmas via education. Thanks for attending today's panel. It's about the controversy regarding antidepressants and placebos. So let's kick it off with some introductions going down the line. If you guys want to just introduce yourselves again and tell everybody what you do.
So my name is Leigh Richardson. I am the founder and the clinical director of the Brain Performance Center. The Brain Performance Center is designed to provide innovative care to people suffering from brain dysregulation. Some people want to call that anxiety, depression, autism, but in my world, it's just your brain's dysregulated. And it's not that hard to put that brain in a regulated state. What I have found as my 15 years as a practitioner is that it is amazing if you do nothing more but calm that brain down, life gets a whole lot better.
My name is Samantha Elliott. I am the co-founder and managing partner of Art of Balance in Chicago. Art of Balance was founded with the mission of increasing access to mental health care to people who are uninsured and underinsured. So presently we have 2 clinics, and the way that we expand access is through ADA accessibility at our clinics, also through having a sliding scale algorithm that makes healthcare affordable for everyone who comes through our doors. And we also hire our clinicians to really reflect through their specialties and their own lived experiences the communities that we're serving at our clinics and in the specific neighborhoods that we serve.
So my name is Bharat Agrawal. I work with pharmaceutical industry, specifically with Hyde Engineering and Consulting. What we do is we specialize in providing support to all the small and big pharma companies, pretty much getting their regulatory approval for the drug products so they can get into the market. So we are a global pharmaceutical servicing industry, and what we do is pretty much if the company is at the ground and if they need to build it, we support them to provide the design and all those kind of services. Additionally, if the companies are already established and they're making the drug product, and if they're having some issues with getting regulatory approvals from either FDAs or European agencies, then we provide them support as well. So that's where my role comes in. Thank you.
Great, thanks guys. So as we discussed, the title of today's panel is called The Controversy Regarding Antidepressants and Their Placebos. So let's get into what's so controversial about it based on your areas of expertise. Is it a controversy? Let's talk about it.
Well, you know, in the world of neuroscience, there's really not much controversy around it because it's pretty well known that the effect that with any medical intervention you do is going to be based on a person's belief in it, that it will work. I mean, the brain, the mind, I use them interchangeably. It's such an amazing organ. The brain weighs 3 pounds, but the brain, everything you do, you don't do, how well you do it, it's all about what's going on in the brain. And it's people's beliefs. If you tell me that you're going to take me out to dinner tonight and buy a $300 bottle of wine, oh my gosh, my brain starts telling me it's going to be so good, it's expensive, it's vintage, it's going to be so sophisticated, and I set those expectations. And it's the same thing when a doctor prescribes an antidepressant pill and says, this is really, really going to help you. Okay, then the brain starts to wire that. I'm going to get better. I'm going to get better. But how many of you have ever picked up a prescription drug and read the ingredients that are in it? I can't even pronounce half of the words. And that's probably a good thing, because if I tried to, I wouldn't understand that. And that would influence what my expectations are. But the brain is truly in control. I mean, the first thing we do when something goes wrong, what's the first thing we do? We decide you need medication. We need the medication to turn that brain on. And the brain is the switchboard for your whole body. And there are other things that you can do to turn that brain on. In my practice, we do neurofeedback, we do neuromodulation, we create neuroplasticity, we use CBT, we use performance coaching, and it all, no matter how you come at it, it has helped me to better understand the relationship between the brain and the body. And that relationship, I mean, your brain is your central nervous system. You've got your autonomic nervous system that controls the rest of your body. And anytime you get in that fight or flight mode, the sympathetic takes over. And anytime you just want to roll down on the floor, you know, and go into the fetal position, the parasympathetic takes over. So the medications, the different things that you can use, even if you just, you know, focus on your breathing, slow your breath rate down, that'll slow your heart rate down. You can get that heart rate and that breath rate to dance together, create heart rate variability. You're going to feel a lot better. And a lot of people experience the same thing. You know, I mean, where's my pills? Where's my pills? And they know that when they take that pill, either if it's an ADHD medication, I'll get my focus. Where's my Xanax? I want to calm down. So I honestly, in my world, there's really not a whole lot of controversy around it.
I would say that to play off of what you're saying, there is such an important role for antidepressants and also placebos in the mental health field. We have to know that these drugs are working or not working, or what the effectiveness of them is. And I would say that from my perspective, where the controversy comes in is when there's not a therapeutic alliance with the clinician who is prescribing these medications. Because as you're speaking to, when you have a positive expectation or a positive experience of these medications, then it's going to work that much better. When you don't believe it's going to work, we have the nocebo effect, where it just won't, even if it's not a placebo. And so where I see a controversy is when we're dealing with clients with severe depression, suicidal ideation, hopelessness, and then if we happen to prescribe them a placebo, then as we know, the placebo effect is not as beneficial in the severely depressed population. We see that it's 75% as effective in more mild cases of depression, but that gap gets larger as the depression gets more severe. So if we are prescribing medications, placebo medications to severely depressed patients, then that medication not working could mean increased hopelessness. That could mean increased suicidal ideation. And so that therapeutic alliance is really important. And where I see the disconnect, especially between the medical and the mental health field, is that we're not collaborating. As a mental health professional, it's quite a challenge to get a hold of my clients' practitioners. And oftentimes, the primary care physician is the one prescribing these antidepressants, and they may not know the client's or the patient's mental health history. And so if we're not...
Do they even ask?
I mean, I've been prescribed antidepressants by my primary care professional, and no, that wasn't asked. But I'm also a mental health professional, so he probably assumed that I knew my own mental health history. But yeah, I mean... when we're prescribing medications without looking at the patient's history, when we're not collaborating with other clinicians in their medical team, then we risk giving the wrong patients the wrong placebos or the wrong medications. And so I think the ethical disparity comes in when we're not communicating with each other.
So I guess I would echo with the thought what Samantha just mentioned, right? I think being in pharmaceutical industry, we work with pretty much scientific data and come out with a conclusion. And pretty much right now, in last 2 days, we have spoken enough about either mental health or data management, right? So one thing which is pretty much driving this debate since last couple of decades, I would see is as the technology advances and pretty much our information is at the fingertip, if a person feeling any symptoms, what he'll do is he'll go on Google, try to find whether I have something or not before to go to the doctor, right? And that's where they'll say, okay, my symptoms look like a depression. Maybe if I'll take the medicine, what happens? And there are a lot of articles and studies, what just Samantha spoke about, that placebo can also give an effect. And antidepressant gives an effect up to a larger extent than placebo, but is it really worth it? I was going to quote about, in 2011, there was a study done from Johns Hopkins Medical Center. What they did is they pretty much used the data from one of the drug, and the drug was specifically saying that when they did the company filed for the approval, FDA asked you to do the double-blind study, right? The clinical trial study. What it is, I guess, just for the pharma people, they might know, but many other people, if you don't know, double-blind is pretty much neither doctor knows, neither patient knows what they're getting, right? So it's kind of unbiased study to get the actual effect of the drug. So from that study, the data came out was 38% patient who had the depression got treated with the placebo. And 60% population who had the depression, they got the drug, they got better result. So again, when you look at the 38 and 60, you say 60% is better. But question immediately comes, that's with the drug. Without drug, 38% people are getting better. Why you really want to get the drug to them, right? Because always drugs comes with their so-called side effects. And we all know there are a lot of side effects with the antidepressant because, these therapies are not like, a week long or 2 week long. These are the month-long therapies. And when you do this long therapies, after that, patient get this dependencies, withdrawal symptoms, and all those things. So that's where this debate has started, that why there is difference. And again, before I'll put my thought, what's right or wrong, I would say, we all need to make a thorough understanding why it's happening, what's the patient population, what are the actual symptoms, and based on that, we should evaluate whether we stand and we can get to some conclusion of it.
But I'd like to comment on, you talked about the side effects. Mm-hmm. I'll ask my clients, because they always say, have you started any new medication, any medication changes? And they'll say yes, and they'll tell me, and I'm like, well, are there any side effects? Oh, I don't know. I'm like, well, you don't want to know? No, because, and I'm like, maybe that's not all bad. Because if you know what those side effects are, then it becomes a self-fulfilling prophecy. And you start, perception is reality. Oh my gosh, they said might feel a little dizzy. I feel really dizzy.
We go back to the nocebo effect.
The nocebo effect, the Latin word, I will harm. Mm-hmm. And when you look at that nocebo effect, it is amazing. They did a study and they looked at, one of my clients was participated in a clinical trial, and he was in the control group for an antidepressant, and he was given the placebo. About halfway in the trial, he and his girlfriend get in a really big argument. He takes the whole bottle of antidepressants in an attempted suicide. They rush him to the hospital. His heart's racing. His blood pressure's just like plummeting. And when he gets to the hospital, the doctor tells him he was given a sugar pill. Immediately, his symptoms went away, immediately. But he had created the expectation in his brain that he was going to overdose. So his body started producing those symptoms. So when people tell me they don't know the side effects, I struggle with that. Should I say, you need to know those? Or should I say, okay, that's something as a clinician I struggle with.
Right.
Well, and it begs the question as well, like if patients have the ability to improve their mental health through a placebo or through a sugar pill, then when do we even choose to prescribe these antidepressants? If we know that they can get better without them, then, shouldn't the medication be the last resort?
But it's not. It's the first thing we turn to. I didn't mean to cut you off.
No, I guess you're right, Leah. Pretty much I think what patient wants today is, they go to the doctor with the premeditated mindset that I need a medicine, right? If doctor tells them, okay, you don't need a medicine, then they're like, okay, why did I really came here? I really needed something I was feeling bad, and that's why I came here, so I expect some kind of treatment, right? So there's always a psychological thing, right? Depression is a mental state of mind, right? That whatever is going around you has given you some kind of psychological effect which makes your mood go down, right? I think pretty much Leigh is the expert in the brain thing, but the way it works is, in your brain, your neurotransmitters, right? There's a serotonin, which is your so-called happy transmitter, which makes your mood swing, right? What happened in the patient with depression is the serotonin level goes down, and that's why you have this kind of issues, right? And that's where, and I guess one other thing which I wanted to mention here is, to diagnose the depression, that's also a very tricky thing. It's not like, you can do a blood test and you can say this person has depression. It's more of how much a patient is open with the doctor, how much he can state out his actual mental state to a doctor, and then doctor can evaluate. Doctor has pretty much a series of questions they ask. Are you feeling happy for the last 7 days? What was the situation? Something happened to your family? Blah, 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 right? And based on that, they rate you in your different scoring. If you are at the lower rating, they'll tell you you are mild depression, right? And then you go with the mild to medium to severe level of depression, right? So all those things are very important to consider when it comes to treatment, right? So who should get placebo and who should get this antidepressant? If you ask me, pretty much any decision, I am not physician by any means, but from my understanding of this topic and the studies were done, right? Any decision should be done based on the risk versus harm, right? We all know there is some harm associated with the antidepressant, but risk with placebo is low. So to me, if the patient goes with the scale, the lower level of depression, you start with the consulting. Counseling would be always a needed thing here. Plus, maybe if needed placebo, go to the medium, then you get some kind of placebo, maybe with start with the mild, you get just the counseling, medium, placebo in counseling, go to the severe level depression, go to the antidepressant and counseling. I think that's the way I think the treatment regime should go.
Well, you mentioned the neurotransmitters, and that's looking at the chemical synapses in the brain. What QEEG looks at are the electrical synapses, and there was a study done that was really interesting because, and this is your field, but what I understand is they do with each antidepressant, they'll do a run-in and they'll use the placebos, and they did quantitative EEGs during that placebo stage, and they found a decrease in the prefrontal cortex in those people also scored less on the Hamilton, which is just a basic depression tool. But you're talking about chemical changes, there is electrical frequency changes. I mean, depression, there's 4 things that puts the brain into a dysregulated state, and genetics is one of them. Physical head trauma, emotional trauma, and stress. So I think I look at depression a little bit differently, but certainly the electrical, the QEEGs will show depression.
Great. Does anyone else want to add to that? I mean, we've covered a lot.
Yeah, not presently. I could go very deep into that.
We'll come back to it.
You mentioned nocebos earlier. Mind kind of clarifying or defining for our audience what that means? Do you want to take this one, Leigh?
Sure. A nocebo is the I will harm state. And it's just like I have the expectation that $300 bottle of wine is going to be so great. It's thinking that, somebody tells me, oh, that neurofeedback's not going to work. My sister did it, didn't do anything for her. That person's going to believe that it's not going to work. And, it's interesting because they've done studies, and not just on drugs, but on surgery. And they have shown that fake surgeries have just about the same amount of impact as real surgeries if the person believes the surgery will help them. I mean, I think I read a study about arthritis. So nocebo, the placebo is the power of suggestion. Oh yeah, I love that. That's going to help me. And the nocebo, no way. That's not going to help me.
Yeah, I've worked with clients who, and we all know these kinds of patients who research the side effects of every drug before they take them. And when they truly believe for themselves that all of those side effects are going to happen, then before we can even expect side effects to be kicking in from medications, they're experiencing them. The drug is not going to work, and they're going to experience all of the side effects. And that's something we see pretty often. I've had a lot of clients who take an antidepressant, and the first night that they've taken it, the effects haven't even kicked in yet, and they have a panic attack because they believed that the antidepressant was going to give them a panic attack. So,
I think my take is a little different for the nocebos, right? I think when I work in the pharmaceutical industry, we need to deal with the data, right? Once we have set population, we give them the medicine, right? You're always going to get some kind of outliers, right? And those are the nocebos to me, right? That whenever you expect placebo should not give an effect. But if you're getting a side effect from the placebo, it's a point of talk. That how you really going to defend it, how you're going to talk about it, right? So I think there's always, and I guess, there's still a lot of science needs to be done to understand all this behavior. But I guess one point which we have mentioned, it's all about psychological. Mm-hmm. And that I definitely echo with, that, psychological thing is having a very big impact on your, whether it's depression or anxiety or any other mental health problem, right? And I guess a step back, before you go to the doctor, I think your surrounding would be the key. Many a times, if you have good surrounding, your family, your friends, if you can talk to them, this kind of treatment may really not need it, right? So I think my take would be that.
How does life stage kind of factor into deciding whether or not to prescribe a placebo versus an antidepressant?
It's, I guess, pretty much what you have spoke here, right? That for a patient, right, to get whether it's a medication or not, how much he's open with his doctor, that's also very important, right? We do this annual visits. I would ask, raise a hand, how many people really does an annual visit to the doctor? Very few, right? And I think that's one of the critical things. Your physician needs to know what's going on with you yearly, right? Because there's a specific aspect to it. Specifically in your family, right? You have a lot of things going in ups and downs, right? And those things affect your mental behavior. So if you have the same physician you go to every year and they have a good rapport with you, then when you come for a yearly visit, then they're going to ask you the same question, and you can be answer to them openly, rather than having some hesitation to talk out, okay, that if she's asking about how's your marriage life going on. You may not be comfortable answering to the question to all the doctors unless you have that good rapport, right? And pretty much in today's world, there's a lot of social stigma because of this social apps, right? And I guess one of the key things we need to understand is the depression, from my understanding, is, the age group of 13 to 25 and age group of 35 to 50 are the main prone group where we have the depression, right? The 13 to 25 are the group who are pretty much so much into social media right now, and this app thing. This affects, anyone gives you a bad comment on your picture, it runs in your mind, right? You need someone to talk out, whether it's your family member or your friend,
or a counselor.
Or a counselor, yeah, again. So those things are important. And if you really talk out, those things can be mild down. If not, it just spins your brain and gives you, I guess, decreasing your self-confidence, affecting your overall lifestyle, and that's where this hurts longer, right? And I think coming back to the life stage thing, for a doctor, right? If they doesn't know you, just with the 20-minute visit, if you expect that they find the actual cause of your depression and give you the correct medicine. That's a lie. We need to understand that, right? And that's why the life stage or the life cycle of your relation with your physician is very important.
Yeah, I would say that as far as life stage goes, we all, regardless of age, have the neuroplasticity to be able to participate in something like neurocognitive behavioral therapy, something that can really change the pathways in our brain to manage or decrease our depression, anxiety, whatever we may be dealing with. And so less than life stage, I would say severity of the depression is what I would look at as far as like who should or shouldn't be prescribed placebos. And regardless of age, someone who is dealing with more severe depression, suicidal ideation, hopelessness, should probably go more for the antidepressant just until we can manage the symptoms, deal with the underlying trauma, whatever is going on with them. And then we can look at tapering off of that. But for someone who's got a more mild or moderate case of depression, we can definitely go for more of a placebo or counseling as opposed to going straight for the medications.
We know when you say life stage, to me, that has as much to do with your environment, what environment you're in. Because if you have a lot of support around you and you have resources that you can tap into, then you have a whole different route that you go. If you're in a situation where you have no support and no options, you're just in a very different spot. Personally, medication has never worked for me. You give me an antibiotic and I get a red rash on my face. Always my face. So it's never been like with my two kids, it was never my first stop for treatment. Now, certainly, my kids have taken a lot of medication growing up because it was needed. So when, I look at, it doesn't matter whether you're 13 or 30, what kind of support do you have around you? And what other options have you tried?
It's interesting you bring that up. I do a podcast, and one of our episodes, our most popular one, is called Kids on Cannabis. And we interviewed a mother of an autistic son who they had tried everything with. I mean, he was on Prozac when he was 4 years old. That didn't work. And oftentimes you find with cannabis, when people come to it, they have tried everything else, and it hasn't worked. So she puts 0.05 milligram drop on his food, which is like nothing, once a week, and it totally changed this kid's life. Wow. And this kid doesn't even know he's taking it. So I think that's kind of an interesting thing about cannabis is like, is there a nocebo or placebo effect with it? I don't know. I haven't done any studies. Nobody's really done any studies in cannabis because it's federally illegal and you can't get grants, but that's going to change. Okay, great. So we talked about nocebos, and we talked about who to treat and when. Obviously, the severely depressed need something that's going to work and help their depression, whereas if they're mildly depressed, you might go with a placebo.
Yeah, or even just a counseling approach. Yeah. And we can build up those social supports through counseling. We can build up those resources. I mean, we can build up so much readiness for change and so many structures that will help people move to the other side of depression or at least be able to manage it in a healthy way.
Well, and 50% of doctors report that they do use placebos to make their patients feel better. I was reading a survey, and it said that 80% of them said that they would recommend a placebo if they thought that it would make their patient feel better. 55% of them said they had done it in the last year. The question is what do you, a doctor can't write a prescription for a sugar pill. So what are they giving them? And, that to me is the big question. What are you giving them? If it's a baby aspirin, yeah, that's great. But what if it's, instead of Xanax, you're giving them, I don't know very much about drugs, but you get the point. That's the question.
And what are they paying if it is like a baby aspirin versus,
Actual antidepressant.
Yeah.
Well, and what's the incentive for the physician to be prescribing those? And I always come back to really, does the prescriber know of the mental health history of the client and the severity of their case? So that's, comes back to the importance of collaboration within the mental health and the medical field.
Okay, great. Is there anything else you guys want to discuss before I do wrap up and we do Q&A?
Well, I would like to say that the placebo effect is everywhere. It's all around us. People come into my clinic and I can tell they're having a bad day. So before, we start with whatever it is we're doing, neuromodulate. Before we start, I'm like, hey, looks like you're having a bad day. And it's called, not everybody in my practice is a counselor and can do counseling, but we can all do comfort talk. What can I say? And a lot of times all you have to say is, how's your day? And let me tell you about it. So just showing that you care kind of creates that placebo effect in itself.
Well, and I mean, the placebos and the nocebos, like you're pointing to, they're all around us. It happens even in counseling. People come into a therapeutic setting believing that therapy is not going to work for them, that what they need is an antidepressant, and we find the same effect where, if they're not willing to participate in the counseling, and if there is no therapeutic alliance, there's no trust or rapport between the client and the therapist, then that therapy is not going to work. So, in that sense, sometimes it is better to prescribe the antidepressant or the placebo, just to get them started.
Yeah, I think this sums up, right? The overall talk also. Pretty much, person gets into depression because of some kind of mental stigma which he is facing or she is facing, right? If you have your support system around you, which can understand you, who can talk to you, talk out the things would be, I think, the biggest factor to come out of this scenario. So I think before we go to the antidepressant or any other medication, I think if you have that support system which you can build around you, would be the key to, come out of the depression.
Mm-hmm. Just made me think of the controversy. Are there drugs, in your opinions, that are more controversial than antidepressants to prescribe to people, such as, I'm thinking opioids, but like...
I think narcotics, opioid, I think those are the specific one we know, right? That they are having very bad side effects, right? Specifically the withdrawal symptoms. If, like corticosteroids, right? Steroids, right? You take it for the relieving of your pain, but as soon as you take off, there are a lot of bad side effects associated with it. So I think pretty much the same thing goes with the antidepressant. So I think there's always, there's a big black label with this medication. There are a lot of side effects, but the benefits outweighs risk. And I think who takes the decision is the physician, because he knows what's right for the patient at the time of his consulting, at the time of his talking. So I think that's where the final decision should come out.
Yeah.
I would say that a pretty controversial mental health drug specifically is benzodiazepines that are often given. They're extremely addictive and they're prescribed for far too long. I've had clients who have been on daily benzodiazepines for 10 plus years and now don't even have the option to titrate off. So the challenge with benzos as well is that they decrease the activity of the amygdala, which decreases our neuroplasticity. So we don't even have the ability, once we're addicted to benzodiazepines, to change that behavior, to really build those coping skills to process that trauma. So it really decreases the patient's ability to learn how to take care of themselves mentally and emotionally.
You're right, but you calm that brain down, and then they can recreate that neuroplasticity that they've lost, and it's all about what goes on in the brain.
Yes, there's certainly a place for it, but from what I've seen, it's far overprescribed.
Oh, totally agree.
Yeah.
Totally.
Yeah, and I'd have to add cannabis is probably pretty controversial to prescribe to people at this point. But,
Are
that's gonna
doctors
change.
doing that?
Yeah, they are in certain states where it's legal,
Yeah.
or medicinally legal.
Yeah.
So, but it's hard to find a doctor, and usually your, primary care won't do it. I mean, they might, but you have a lot of cannabis-specific doctors who you go to who prescribe it to you or give you a card. So that's a controversial one as well. Okay, so nothing else you guys want to add? I was going to wrap it up real quick, just kind of summarize what we talked about. So it's not necessarily a controversy, what we learned. It depends on a number of factors, kind of what field you're working in, how depressed the person is, what their life stage is. So I can, some parts of it, like we discussed, giving a placebo to someone who's severely depressed would be controversial. Mm-hmm. And then in terms of placebos, they can have an effect and be effective for the mildly depressed. And then there's something called a nocebo effect, where when you prescribe someone something and tell them it's not going to work, then they think it's not going to work. Or if they think in their own mind it's not going to work, then it's not going to work, because it's all mind over matter, which I think is fascinating. Okay, so we're going to wrap it up and do a Q&A. Do we have any questions from the audience?
Hi, thank you for that information. My name is Alejandra. I'm a registered dietitian. I own Functional Bites. And I guess my question is for any of you, I know that nutrition plays a huge role in someone's health, so I wonder if nutrition plays a part in your treatment of your patients, whether we're talking about gut health or nutrient deficiencies. And if it's not, do you foresee that changing in the near future?
Yeah, I mean, my master's is in health psychology specifically, and the majority of my client treating career has been around therapeutic weight loss in the bariatric setting, and I've also worked with chronically ill and acutely ill patients, end of life treatment is something that I've done. And nutritional psychiatry is something that I've studied quite a bit and have utilized a lot with my clients. You know, we can actually use nutrition to replace antidepressants oftentimes, because nutrition and various macronutrients have such a big impact on our neurotransmitters and, you know, the chemical balance in our brain. So yeah, I would definitely say that it's not something I see commonly in the counseling setting, but definitely in the health psychology realm, it's up and coming.
Well, and I definitely diet. There are two foundations that we first talk about in my practice, and it's diet and sleep. Because, you know, how's your diet? Oh, it's okay. Well, tell me about it. Well, I only eat fast food, like, you know, once a day. I'm like, my whole thing, I mean, because it's processed, and I don't have the knowledge that you do there, but I know enough to say if it comes in a bag, a box, or a can, and it's going to be good for 2 years, you don't want to put it in your body. And, I mean, when you think about the brain, it's easy. Brain food, blueberries, avocados, salmon, it's not hard. Now, does everybody have access to that type of food? They'd have to work to get it. But from a nutritional standpoint, stay hydrated. Drink lots of water. The brain is 70% water. If you do nothing more but keep yourself hydrated, that will help.
So I'm Veronica Seeberger, Cognitive Performance and Health. I'm a registered nurse as well as a board-certified neurotherapist. So we also do neurofeedback in our office. And one of the tests that we also offer our patients, I'm not sure if you guys have heard of it, it's called the GeneSight psychotropic testing. And this is a really important test to see how the patient is actually metabolizing medication to see if it's the right medicine for them. So not a lot of doctors' offices offer it. The patient can go online and get it. So that's really a safe way to really consider what medication they should be on or be prescribed. I think the other issue that we're seeing here too is, you know, patients only have 10 minutes to visit with their doctor. So, and in most cases, you know, the doctor's doing a really quick screening or they're doing a PHQ-9 to see what their depression levels are. But I think, you know, really taking it to the next step, depression is really exhaustion, being really, really tired. And when they're so tired, you know, they can either go into that really depressed state and they get really anxious, they go depressed. We see this a lot with kids because people are not sleeping. And we really need to start looking at the Pittsburgh screening to see what's your sleep hygiene? What does that look like? And nutrition, of course. You know, what are you eating at night? Are you drinking a cup of Cokes before you go to bed and that's not helping you to sleep? So we really need to do better with our screening with the patients before we get to the next level. And another problem that we're having in our system too is referrals. Referrals is like cyberspace. You know, you send a referral and it's fax after fax and no communication, no one's called me back. People are getting really, really frustrated. So that's what we see. We stepped out of that, so we're a direct primary care provider. We don't do insurance. Patients pay us directly. And there's a lot of accountability on our part and on the patient's part, and they really like that because they're investing their time in us and we are investing our time in them. And we just cut out the middleman. So anyway, that's my take.
Yeah, I would say that definitely to what you're saying, the referral process is hard, the communication is non-existent, and the doctor's visit is 10 minutes before we're prescribing medications. And I think especially for psychotropic medications, it's really important that we do a full psychiatric evaluation, which oftentimes doesn't include, and at my clinics we do include it, a full lifestyle assessment as well, like what are your sleep patterns, what is your nutrition, what is your physical activity level. We're doing a full lifestyle assessment inside of our psychiatric evaluations, and I think that that's really valuable to take on as a standard in the industry.
So that is an amazing presentation. The whole panel and both of your questions were absolutely fantastic. Is there any maneuvering inside the psychiatric space to help general pediatricians like myself, general family docs, general internists who don't really have the psych background? And many of us, we're the ones who the patients come to, and then we don't have the expertise. So, and then unfortunately our litigious world being what it is, we're afraid to prescribe anything. We're afraid not to prescribe anything. We're damned if we do. We're damned if we don't. We're damned, damned, damned. The patient's damned. Everyone's damned. Please help. Sorry.
Well, I'd like to respond to that. And I've said this to a doctor here that I was speaking with yesterday. Sometimes doctors are my biggest barrier to clients because they don't understand the neuroscience, look at it, perspective. And the doctor I was talking to was like, this is fascinating. This is brand new stuff. And I said, sir, this has been around for 50 years. So I think that we all, as a practitioner, I feel like that I have to keep myself updated because, when I started off in 2005, I had stars in the eye. Oh, it works for everybody, 100% of the people, and nothing works for everybody. So I'm continually looking and keeping myself educated as to what else is out there. I'm not licensed to give out meds, but I sure have a referral list that I can turn someone to. So I think that the more we can collaborate, be open, and educate ourselves on alternatives to medication. I mean, you're right. You're damned if you do this. You're damned if you don't. You're damn.
Yeah, definitely. We also, at my practice, we have a referral list, and I encourage each of our clinicians to go out and really market for themselves, create relationships with all different kinds of doctors. So, so not only are we referring blindly to somebody that we're hoping is going to pick up the phone, but that we have a relationship with those doctors. We're going out to lunch with them. We're sending holiday cards to them. We're making sure that that we have this reciprocal relationship where they trust us, and when they see a patient coming in from our referral, they know to pick up the phone because they know where that patient is coming from, and vice versa. When we have patients coming to us from a known doctor, then we also know that the therapeutic alliance is going to be set up really well, that doctor is going to say, this is a trusted clinic, I believe in them, like, get your treatment here. And so that client is going to come in trusting us already, and the therapeutic alliance is already created, which means that behavior change is going to happen so much more naturally.
Yeah, I think my take would be, I think one of the things talked in this earlier keynote presentation was talk of the clinician to clinician, right? I think that's the key, what we're talking here right now. But I guess it begs a question that as a clinician, do we really know that this symptoms goes to this doctor, right? When do we really need to go to this specific doctor? I think that's where the internal talk of the clinician to clinician also needs to be there. I think that's where I see this going. And I guess pretty much since last year, we have seen this has grown tremendously, that people are pretty much connecting and talking out and collaborating with all possible thoughts, and that's where I think the future is. So I see, hopefully, in near future, we'll have more open-ended, and rather than confining our patient, okay, I don't want to share my patient to other that's not the way we should be doing, I guess, right? I guess that might be the answer to this.
There's no kind of like online network or resource where people can come together, doctors of all different types, and share referrals, share information, connect. Are there any people from the internet?
Facebook groups?
I see an opportunity there.
Yeah,
an app or
yeah.
something.
Were
Yeah,
there any
definitely.
tech people in the audience from the tech conference? Maybe they could help us out with that. Or there's an idea for you.
Yeah, certainly COVID created a pretty big challenge because, I mean, what we would do prior to, and what, you know, we thankfully can do now again is just go into the hospitals, go into the doctor's office and say, you know, I don't have someone from this specialty on my referral network, and I would like to form a relationship. But when we can't be in person with people, then that definitely creates a challenge and a barrier that hasn't really been filled by any specific technology that I know of.
There's an opportunity.
Any more questions in the audience? No? We're good? Okay. Well, that wraps up our panel discussion on the controversy or not around antidepressants and placebos. So thank you for attending and have a great rest of your day.
Thank you.